Hello everyone, it's Paul Glasgow here for the fourth BESI webinar. I'll just wait another minute or so as all the participants are coming in at the moment. Okay, well I might get going with this, the fourth of the BESI webinars. And I'll just give a brief introduction before we start our speakers this evening. As you're all probably aware, BESI is about the behavioural, environmental, social and systems interventions that we need for trying to reduce the pandemic. And we've talked in the previous webinars mostly about the behavioural, social and systems ones. So it's a pleasure tonight to be able to talk about the environmental ones as being equally important. Just a little bit of background about what is BESI. It's a global initiative that started with myself, Susan Mickey and Jeremy Grimshaw. And the primary objective is to reduce viral transmission to achieve zero COVID-19 using the BESI interventions, where we're looking to do research which will maximise the effect and minimise the disruption. A longer term objective is to reduce the likelihood and impact of any future pandemics and to help build back better. We recognise BESI needs to address this as a global issue, that it's interdisciplinary, that we need multiple disciplines involved in this, and that we'll need to involve stakeholders at all stages of this, because we also need a translation of evidence into policy and practice. So it's a two-way street. I've been through some details about the research strategy, but one of the things we're currently doing is trying to develop a set of BESI principles, which we will post onto the JISCmail website shortly. We're just still in the mode of redrafting these, but roughly the principles will be like this: that we need to optimize the effectiveness of the interventions, that we recognise that there are substantial variations in practice across countries and regions within countries, and that we're often failing to learn from those variations in practice and work out what are the optimal things to do. That to work those out, we need all the four components of BESI, the behavioural, environmental, systems and social disciplines, to work those out. That in working out the behavioural ones in particular, that we need a detailed understanding of the barriers and enablers that would enable the appropriate behaviours to be put into place. We also recognise that there's a bit of research that's going on at the moment, but we desperately need replication as well. And that's to look at the different cultures and contexts, as well as showing that the results are repeatable, that we need the generalisability as well. And particularly important is the fact that COVID transmits and hits different groups in different ways, and that there are vulnerable populations that we specifically need to make sure that we're integrated into any research components, as well as into practice and policy. So as I said, we'll be posting a set of principles a bit like this. We'll be editing them a bit before we post them, but we'd love to get people's comments and input on those, and to get organisations to sign up to these important principles. So just before we introduce this particular webinar, just to alert you that there are a couple more this year. The fifth webinar is now scheduled for Thursday, the 26th of November, which will be learning from international successes during COVID. And we'll be hearing from both WHO, but also from the success in Uruguay. And the webinar 6 will be on the 10th of December, and that will be about mapping the evidence, and we'll confirm the time and speakers with that on the BESI website shortly. And then we'll close with an end of the year webinar, which is more of a discussion about the future of BESI, where we would really like to get your views on how we can take things forward with the BESI collaboration. So at that point, I'm going to hand over to Jeremy to introduce our speaker for the night.
So thanks, Paul. I'm Jeremy Grimshaw. I'm a senior scientist at the Ottawa Hospital Research Institute. I would like to welcome everyone to the call, and also our speaker, Dr. Leora Malki-Epstein. I have to confess, this is one of the webinars that I'm kind of most interested in, because I know nothing about engineering and how that can help us tackle this problem. So I've been looking forward to this one. You can see that when we planned this, we expected to have 3 speakers, all from the UCL Department of Civil, Environmental and Geomatic Engineering. Unfortunately, for various excellent reasons, neither Nick Taylor or Lena Siric can join us today, but I'm really delighted that Leora has basically worked with them and will present some of their work, so we'll get at least an idea about the breadth of stuff that's being done. Again, one of the things that Paul has said is that what we need is interdisciplinary research, and if you actually read the bios of the 3 speakers we planned, you really get a sense of a very interdisciplinary group that clearly is working together on really gnarly, difficult problems. And I think that's quite exciting as well. So to say a little bit about Leora, she has a multidisciplinary background in atmospheric physics and geophysical fluid dynamics, and enjoys applying physics-based approaches to projects in research and education that address some of the urgent threats facing humanity of climate change, natural and environmental hazards. Within her work, the recognition that COVID-19 is an airborne, has some airborne transmission, really raises the issue about ventilation indoors in crowded space. And so basically she's been looking at that and trying to understand how we create safe indoor airborne environments, and in particular applying this to public transport, which is clearly a key area, particularly for groups that don't have other means of getting around the place. And already the work that she has done with other colleagues is being implemented by Transport for London. So I'm just going to have one more slide before we move on to Leora, and this is just to talk about the process. So if you've been on these webinars, you know what we do, but what we'd like you to do is type the question and answer, or use the question and answer function to type in questions. You can do that at any point in time during the talk or during the discussion. We will sort of note them, and then we'll actually make sure they get sort of answered. Sometimes basically in the chat box itself, in the Q&A box itself, but other times we will we'll bring them into the discussion, and if possible we'll probably unmute you to try so you can actually sort of both ask your question in person and contribute to the discussion. So I think that's all I had to say, and as I said, it's I'm really looking forward to this. So Leora, thank you so much both for being with us today, for quickly stepping into or stepping up, and also being able to cover some of Nick and Lena's work, and I'm delighted to welcome you. So over to you.
Thank you very much, and thanks for the introduction. I will try to do a good job of expressing what they have been trying to achieve. And can you let me know if this is sharing the right screen at the moment?
Yes, you can see a bus.
Great. And is it, sorry for asking again, is it also showing it in slideshow mode, or is it still showing the overview?
No, not yet.
Not yet. Okay, so let's just get that done. And now?
No.
So I might need to stop sharing and share a different screen. Sorry about that. This is the danger of working with a few screens.
It did come up in slideshow when you first started, Leora.
And now, not yet, no. Okay. When I first started, it came up in SlideShare. Okay. So does this work?
Not in slideshow for some reason.
Oddly enough, because that's how I set it up. Apologies for that. I know this happens all the time to people, and I'm not sure how they normally resolve it.
The way I usually do it, Leora, is to start the slide share, so the screen show, and then do the screen share of the if you've got two screens set up, you then do the screen share of the one that's got the slideshow.
Okay, we'll try it. No. Well, if it doesn't work, I will just show you the full screen in any case. Okay. Resume slideshow. How about that?
No.
No. Okay. But can you see the full screen though?
Yeah. You can. Yeah.
So shall we proceed like this? It might be easier than spending a lot of time trying to get this to work. Okay. So yes, my apologies on behalf of my colleagues today. What I'd like to talk about is work that we've been doing already since April with Transport for London that relates to a lot of work that is being done around the sector on engineering approaches to COVID and how to actually improve public spaces and interaction, and with my interest specifically focusing on indoor air quality as an attempt to actually protect people from themselves almost. And I'm quite keen to hear from the rest of the network and the participants afterwards on how we can get the message across to people that they do need to be careful and stay safe, and yet at the same time without alarming them too much or making it so overwhelming that they would rather not engage with it in the first place, or rather even not leave their house at all, which is something that we've already been seeing. So if I can present the project UCL Viral. Initially, we were working completely just ad hoc and pro bono, just trying to help TfL very quickly in the early days when very little was known about this virus. We then managed to also get UKRI funding, and the project is now quite big. It is led by Dr. Lena Sirik, who couldn't be here today, with myself, Nick Tyler, Thorsten Stosser, Taku, and our researchers, Alex and Philippa, who are doing a lot of the work. And of course, we're collaborating also with a project called TRACK that is led by Kath Noakes and supported by the Department for Transport. So our approach to looking at increasing safety has been to look at a combination of different engineering methods and different scientific methods of finding out what is going on actually on public transport. And this is an approach that you could apply also to any other kind of indoor environment like buildings. Buildings, public places, schools, residential buildings, hospitals, in the not in the ward, but perhaps in all the other patient waiting areas, etc. So we look at a combination of airflow simulations, air quality analysis, and I'll try and explain how that is done, passenger crowding, because people are the key element to all of this, and microbiological surveys that look at what's happening in the air as well as on surfaces. And we are aiming to tie all of this together into a framework of risk assessment and interventions so that we can actually make recommendations how to improve the situation going forward. So if we start by looking at virus transmission, what we figured out in the early days from the initial publications around, we know that the virus obviously is transmitted by the virus SARS-CoV-2, that's what causes the disease COVID-19. It was said up front that this was spread by close contact with an infected person, although it was very difficult to identify how specifically that close contact is taking place. It's spread also by inhaling droplets or aerosols that contain virus particles. And it's spread by touching contaminated objects and then touching your face, although increasingly it's not really clear that that's one of the mechanisms of transmission, but we are considering all of them. If you've heard in the literature or discussions about viral load, that would be the number of virus particles in a sample that is produced by a patient. So for example, how much of the virus exists in their throat or in their nose, in mucous membranes or mucus that they are producing. The infectious dose is the number of virus particles that are required to cause an infection. So something that we've always tried to get across to people that we've been working with is that you're not trying to protect yourself from some kind of hideous radioactive substance that could kill you on contact with one individual particle. The human body has defenses against viruses. We defend ourselves against viruses and bacteria all the time, but there is something to do with the dose, and what can cause an infection is if you're exposed to a higher dose for a prolonged time. And these values are unfortunately still not entirely known. There are various estimates, and there are many things that were learned from the predecessor to SARS-CoV-2, which is the SARS virus. But we've had to rely on many estimates. And this is one of the first things that engineers do, is they guesstimate, and they try to draw from knowledge that comes from all sorts of different scientific domains and actually make a decision. And the way we like to look at it is, there's a fire in the kitchen. A physicist might calculate in great detail how much water precisely is needed to put out the fire, but an engineer would simply run in, take a bucket of water and throw it on the fire. So that's the kind of approach we've been trying to take, and to act very quickly. So we've always taken a very defensive approach to all of this and asked ourselves, how can we protect passengers in this kind of environment, regardless of their cooperation? Because it became clear very early on. We were brought in to look at protection of bus drivers. We're all international, most of us are international academics. We were aware that even in some countries, bus drivers were physically assaulted by passengers when they asked them to put face masks on. Early on in this research, in this project, it was still not possible to ask passengers on public transport to even wear face masks. So we've always adopted the approach that we need to protect the driver no matter what, and then that we need to protect passengers from themselves and from each other. So one way to do this was to look at the air, and there was a raging debate between aerosol scientists and environmental fluid mechanics experts with the WHO and the CDC and the Public Health England. The aerosol scientists and environmental fluids people insisted that this virus appears to be airborne indoors, which means that if you are in an indoor area with poor air quality, not enough access to fresh air, not enough air moving around, you're more likely to be breathing in higher doses of this virus. And that became recognized after several months. And we were quite happy about that, because we had a very strong feeling that high standards of ventilation could really help. And we're also very concerned that society has to adapt to some kind of new normal, and that unless we create the right conditions for people to engage, they will not be able to resume normal life, go to work safely, go to school safely, go to see their GP, and all with an underlying sense that they are safe enough and that the risk is being managed and minimized, even if it's not completely eliminated. So our focus has been very much on public transport, but of course we've been involved in discussions with people from different domains. And our early recommendations on indoor air quality are being implemented by Transport for London. The first phase was really to increase protection for the bus drivers, and I'll show you a little bit of the results of that. Improvement in ventilation standards, so aiming to improve ventilation in general, and in the immediate term, opening windows, increasing cleaning procedures, and starting to carry out testing and research in collaboration. So of course, soon after we did start this project, soon enough, it was determined that face coverings have to be used while traveling on the services, but people do not always wear face masks. Because of today's announcement or last night's announcement, I do have to remind everyone that people don't always get vaccinations. And many people around us, in fact, do refuse to get vaccines for other infectious diseases, which in some cases, like measles and tuberculosis, these are diseases that are far more infectious actually than SARS-CoV-2, although we've all kind of adapted to living with them and being aware that they exist. They still are out there. And our feeling was that even when this pandemic is over, which we hope will be very soon, there's a really good reason to try and improve the safety and quality of the air that we breathe and the hygiene measures and cleaning procedures, because there are other diseases out there as well. So as I've said, I think I've already said this, that the infectious dose and dose of exposure are still unknown. We do know that they're important. We were wondering about buses. We were not sure initially how they would be run and operated in this time. We're very pleased that they are actually running at much lower occupancy. So before the initial lockdowns and before COVID, you could have very, very high occupancies at peak time, and that could be even 80 or 90 people on a double-decker bus in London. And we also are aware that bus, train, and coach journeys can be prolonged journeys that would increase an overall exposure for an individual passenger. And I do have to put the caveat, if they were to be exposed, because in fact, the risk that any one passenger is exposed to someone infected on the train or the bus next to them, the probability of that is quite low. But of course, if they are sitting next to someone who's infected, and if they do get infected, as far as they're concerned, that's 100%. And the fact that the probability of that was low wouldn't help them very much. So we do want to make sure that if an asymptomatic person is sitting next to you, or that a person even who is infected is sitting next to you, that we can help minimize that infection actually taking place between you, that transmission taking place. So in terms of methods, I obviously don't want to go into a huge amount of detail, but to give you a sense of what kind of work was being done and what kind of work we're continuing to do. Airflow simulations are very popular. I think many of you would have seen simulations on various media to understand the details of airflows and aerosol transport on buses and trains. We want to use computational fluid dynamics. In this case, if you've ever heard of them, these are very high resolution. They're called large eddy simulations, and they can give you really detailed airflows and concentrations. This had to be run on the Met Office supercomputer, and we are very grateful for their help with this. And we are planning going forward to carry out much lower resolution models so that we could carry out more of them more quickly and for more case studies. One thing that became apparent in this is a simulation of a passenger standing next to the assault screen of a bus driver. The bus driver is inside. At this point, we were looking at simulating the case where the assault screens were not modified so that no engineering protections were put in place in order to see what would happen to that cloud of coughed and exhaled breath of the passenger. And we can see how this cloud of aerosols or exhaled breath is moving around the assault screen. And of course, what everyone wanted to know was how much of that would end up inside the driver's cab. And what would happen if they are sitting there exposed to that. So the simulations sometimes can look quite scary. This one in particular is actually showing you a speed rather than a concentration. The color scheme is there to just to illustrate the airflow, because otherwise, obviously the problem with air is that it's invisible, which is what makes the idea of airborne diseases quite frightening. And yet visualizing them does not always make it less frightening, because we do have to emphasize what we're seeing. So if a passenger is standing here coughing and breathing out for about a minute, this would be the kind of cloud of air that you would see moving around, and with the color scheme being a bit exaggerated, as I said. We had to run a very large number of simulations for this particular case, and it's a very good example of what kind of questions people would start to ask. What happens if you cover the assault screen? What happens if you change the boarding from middle door boarding to front door boarding, which is the normal operation of a bus? what happens if the passenger moves 2 meters back? Would that help? And we tried to model all of these and eventually bring them into a unified air quality framework, because these simulations take weeks to run for every single simulation. They actually provide almost too much detail, and yet at the same time, they don't really tell you whether a person will even be infected or not. All they do is show you the airflows. So we try to kind of bring it into a framework where we're looking at the concentration that is experienced by the driver inside the driver's cab. And if you saw earlier, this is the image of what goes on inside a bus. These would be results from simulations when you look from the top, so from the ceiling of the bus, and the driver is here and the passenger is right here, where I have my cursor now. And the cloud of aerosols that the passenger breathed out has been moved around the bus. And we have here results from all the different case studies we looked at, with all sorts of different configurations: open the front door, open the middle door, open the window, change the screen gaps, change the screen holes, the speech holes. And here we could just put them all on one graph and say, well, in the best case scenarios, the concentrations drop to almost zero or actually zero. In the worst case scenarios, they are higher than that. They were still never incredibly high. We are talking about, parts per billion or parts per million, but because we don't know how much virus is needed in order to get infected, we have to provide a kind of general number or concentration, let's say. And this is the sort of thing that can be difficult to share with people, because it's maybe not that accessible and easy to interpret and understand the results of. Based on the work, and this is where it all becomes very practical, Transport for London followed our simulations. We did run the simulations for many months, but we also had they also had discussions with the bus operators and drivers unions. We presented the work to them. They did become convinced that the modifications to the assault screens were good enough that drivers are safer on the job, and that included all sorts of things like sealing around the ticket machine access. And if you've ever been on a London bus, all of this will be really familiar. But basically trying to enclose the driver in their cabin as much as possible, without necessarily making it airtight, or as we said, it doesn't have to be nuclear proof. It is still just air. There is also air coming in from the driver's window. And we felt that this increased their safety by 97%. So this is the kind of work that then becomes implemented. What we also recommended to TfL, besides modifying the assault screen, separating the air from the driver and the passengers in terms of air supply, improving the ventilation systems for the driver as well as for the passengers in general, opening the window in the driver's cab and opening the windows in the passenger saloon. And it became clear also from the results of the research that returning to front door boarding was absolutely fine, and operate boarding procedures in such ways that both the doors were open actually increased airflow and made the buses even safer. We're now aiming to go forward and actually take measurements on buses and trains and see what the air is actually like and see how clean the surfaces actually are. So just to give you a brief overview on the issue of passenger crowding, and these are really the issues that my colleagues would have been discussing. So I'll just present them very briefly. The aim is really to investigate distances between passengers and the direction in which they're facing, and what of the interiors they actually would be touching. This will mainly be done on the underground trains, and to try and understand the relationship between passenger density and the risk of them getting infected. Because once again, for all of the guidelines that have been given, we don't know how passengers actually behave when they are on a train. And are they sitting close to each other? Are they still hovering over each other? Are they crowding, or are they taking a step back and saying, I won't get on that train, it seems too crowded, I'll get on the next one. And certainly what we completely want to avoid is the situation in this picture, which is the pre-COVID situation that was very common on the tube. It is clear that greater spacing is absolutely key to all of this. Greater spacing means that people have more of a distance, so the droplets are less of a concern, droplets that are coughed on directly onto people. It also means that the air quality improves because there is much more fresh air compared to the number of people on board. And in terms of passenger crowding, it's a really important thing to look at going forward. How do we increase the off-peak occupancy and reduce the peak time occupancy so that we can avoid these numbers of people on any given bus or train? And along with that, how does society adapt to that? How can we change working patterns? How can we reduce capacity of the workplace, maybe by slowing down the rate at which people approach a building? Maybe some of them arrive at 8 and others arrive at 9 and others arrive at 10. Of course, alternative workspaces, and all of us are working from home. But of course, we have to have a very good transport system because not everyone can work from home. So I guess the main question I'm kind of leaving for the group now is how can we increase cooperation with health and safety measures? How do we make sure that without alarming people by showing them scary pictures of the virus and how it goes around, that they still want to cooperate, actually, that they want to wear those face masks, that they don't attack someone for asking them to do that, that they keep their distance from each other and behave sensibly, and don't forget that they're in a pandemic, but yet at the same time do not become so fearful that it impacts their mental health, and the mental health especially for children and young people and young adults, as well as the elderly and vulnerable. And in fact, everyone is suffering from this. So I think I will leave you with that thought, and I'd be really keen to hear from everyone else at this point.
Thank you, Leora. That was absolutely fascinating. And I've got questions and thoughts, but as chair, I will hand over to the questioners. And we already have one question in the Q&A box. So Lucas, would you be able to unmute John Obridbite, who's got a very interesting question? And John, would you like to ask your own question?
All right. Okay. Can you hear me all right?
Yeah, we can. Welcome.
Thank you so much. It's super. And to put together such a big project so quickly and get it funded, I'm in awe. Well done. I think I was thinking what a real challenge it is not knowing the viral load for infection and the possibility of this load maybe being different for different people. And that leads me to think about, given that we're looking at a multidisciplinary approach here, how do you scan the literature and update your analyses to take account of new knowledge from other disciplines? For example, the CDC changed their recommendations because they followed the point about successive short exposures of equal risk to one longer exposure. And so the question there is scanning. And then the second thing is, do you get back to your customers and say, with this update, we can adjust our recommendations to you or the earlier report? The last thing is, why is it a should wear masks rather than must wear masks or pay £100 fine? I don't expect you to answer that, but it's more a rhetorical question. Thank you.
Thank you so much. I can only answer the second question with an exasperated sigh. It should be must. I know that there are sensibilities around certain groups of people who cannot wear masks, but I felt that in the same way that you have the baby on board badge, it's quite possible to have those. I think there's sunflower badges that alert people, I have a reason for not wearing a mask, please forgive me. And yet all the other people around them could wear masks. There's also something about the fashion industry being able to adapt and provide all sorts of face coverings for us that might be more comfortable to wear and cause less anxiety to some people. So we really felt early on that that's a problem that could be resolved if it needed to be. And from our perspective, it needs to be. To answer your first question, it's been a very challenging project. We I mean, basically, sometimes it's just been, not being able to sleep at night because new information comes in all the time. There are new papers published. This is a field where a research project like what we're doing now, we would normally expect to plan that for several months and then carry it out over 4 years at a leisurely pace when all of us are also healthy, not worried about our families and finance and the pandemic and the world. And instead it all happens very quickly. So we actually even follow people on Twitter. There's a large group of academics who are very active on Twitter, and especially the aerosol scientists have become very vocal out of necessity. And that helped also to convince the medical scientists that some of the research they were basing their assumptions on was 100 years old, and that new things have been found out. In terms of our report, for example, the work with TfL, we did update it literally every single week. But I'm pleased to say that our original assumptions and advice actually were correct, that they did not need to be updated. It's just the numbers that are not clear. How infectious is it? How long can you be in a particular place? All of that is not 100% clear. And we can draw on SARS as an example because the two viruses are related, and learn from what people in the Far East have done. And that's their behavior that we've observed. Wearing face masks was instantly implemented. It's become an absolutely ingrained habit that is universally accepted in countries that had previously had SARS. And that says to us that measure has been effective.
Thank you. And I should have said John is from Karolinska Institute in Sweden. So other people who want to ask questions or make comments, you don't have to type it all out. Just say who you are and then we'll unmute you. So it's less work for you. So Jeremy would like to come in with a question. And while he does that, if you've got any questions or comments, do type them in. Jeremy.
Leo, that was great. One of the things when I introduced you, I said I was very impressed by the interdisciplinarity already of the group you have at UCL. But I think your last question suggests that there are other bodies of expertise out there, other disciplines that might be helpful to move this forward. And I've always been thinking that to address this pandemic, we need to bring together groups that maybe have not collaborated traditionally with each other. So I'm kind of interested in what are the kind of areas of expertise or out there that you would like to pull in to help you with your work, and kind of what are the insights you'd want from them?
That's a really important one. I think we in terms of practical implementations, it's about collaborating with TfL and seeing how things work in practice. Because
Transport for London, for those people in the world who don't know what TfL is.
Yeah, sorry, that's an important point. They manage all the transport operations in the city, so they run all the different buses. It's a kind of umbrella group that coordinates all the different bus operators and the underground trains and the overground trains. So in fact, we've learned the most from that practical implementation. In terms of articles we read, it's everything from virologists to medical scientists to aerosol scientists. And in terms of the practical implementation, it's how ventilation systems are set up in practice, what works. So I think we have been bringing in a lot of people, but it's probably the medical scientists that were that was the biggest need, I think, because it's not so much, it's for us to understand also how transmission typically occurs and how patients behave and how they, and under what conditions they would come to a medical professional and say, this is where I think I've been exposed, or this is how, these are my interactions, and this is where, because we don't know, in fact, if people normally are infected on public transport. We hope they're not. We hope as well that all the safety measures have already helped. But we don't know whether a person who has no other social interactions and no other underlying health vulnerabilities found that the only place they could have been infected was public transport. And for that, I think the medical scientists and the epidemiologists have to look into that, really. It would be really good to hear from them.
So before I bring in Terry, I think this issue about where people are getting infected is absolutely key. And we know so little about it. And actually, it's a really important methodological question. How do we actually get that data? There's a global database that I read about of super spreaders. I don't really like super spreaders. I like super spreading events, but defined as people who transmit to at least 5 other people. And when I last looked at that several weeks ago, it was 97% of those, the transmission had happened indoors and only 3% out of doors. So I just wanted to ask about whether that is still the case, because it's quite a stunning statistic and one that could be made much more use of, I think, in communication campaigns. And in terms of the kind of disciplines which could add to what you're doing, I'm just aware that one of your first questions when you spoke was how to get people to stay safe without overwhelming them emotionally. And you ended by saying, how do we get more cooperation of people with health and safety measures? Now, these are behavioral and psychological questions. So I was very surprised you didn't say behavioral science.
Sorry, because I had said it before, I only added the ones I didn't mention before. This is why we're here as well.
Yeah, absolutely, absolutely. And I'm thinking it'd be great to have other conversations with you. But I'm on the UK government's Behavioural Science Advisory Committee. And actually there's lots of papers we've published that are on the website that kind of address these very issues, which might be of interest. Okay, so a lovely comment from Carla Henning. Leora, you might like to look at, really appreciating the work you've been doing, but also over to Terry Kemple from the UK to ask a question. And then Jeremy wants to come back again.
Yeah, it's really that clearly there's lots of unknowns, but will in our post-COVID world, with our new awareness of how diseases are transmitted, I mean, in theory, we should then be able to reduce a lot of the other seasonal infections that we all suffer from. So is a benefit that because of this increased knowledge that we will reduce these transmissions, or will we just forget about all this as soon as the COVID infection is over? It's a behavioral question, really, because there's always this tension between what we know we should do and what we actually do. For instance, washing hands.
To me, that is so important. I think, as you know, one of the approaches we took was to say air quality needs to be improved, because if you have certain standards of air quality, then no matter how people behave, then you have something that you have a target you're aiming to achieve, and you have passive controls that actually do that regardless of the people's behavior. But that only works up to a point. And even maintaining the momentum on that, we know that from the air pollution subject domain, that, you know, there were years where nobody was interested in air pollution. And now at the moment, it's actually very much on people's minds. And that has an impact on how the interventions are actually taking place and what is actually done in the end, how decisions are made and how money is spent. So I'm very keen for this to not be forgotten, but this is where it's quite useful to see in a forum like this, you know, when you're presented with the evidence, like the airflows and the concentrations and the idea that you're actually sitting in a room, breathing in what someone else has breathed out, that if you're in a super spreader event, like, and especially those, to also mention what, to respond to what you said before, Susan, those tend to happen very much where people are particularly breathing heavily. So either in choirs or in religious services where many people are praying loudly, or in sports arenas. And, you know, is it helpful actually to be presented by that? Because I also know from talking to many people about my work, with some people, the shutters come down on their eyes when you start talking. They really don't want to know. They want to go about their lives. They don't want to be scared all the time. And they would rather disengage entirely than just say, I'm going to be sensible and do as much as I can, and then I'm going to sleep well at night. It's very difficult to get that balance.
And I think what's needed is to really embed things in a cultural change so that it's just accepted. I mean, when I was a child, everybody washed their hands before meals. It's just what was done. My children's generation and their children, none of them. do that routinely. I went to dinner a couple of years ago with an Asian couple, and I was amazed. We sat down and talked at dinner and then ordered the meal, and then they both went off to the washroom to wash their hands before eating. So these things, just as they can be lost, they can be adopted. You know, nobody picked up dog poo when I was a child. You know, nearly everybody does now. But I think it's about getting these behaviours taken up at scale and maintained, and that means really multifaceted, building it into the fabric of what everybody does. And just a little thing about buses, I've probably been on a bus 10 times, probably in the last couple of months, and only on one occasion did I not go around opening the windows. The windows were shut. But never have I come across anything that's ever suggested I should open bus windows. Why not? Why isn't there a campaign just saying if you get on a bus, check the windows are open and open them? You know, so there's a huge room for improvement really there, I think.
And then there's the worry about either alarming people and frightening them, or unnecessarily, or at the same time not wanting to sound so sanctimonious and constantly telling people what to do. So it is a really challenging one when you're the one that has the evidence that you want to share. How to share it in the right way that will make people want to cooperate.
Yeah, of course, and that's what we do.
Yeah.
Jeremy.
So the other thing I was thinking about, John was talking about sort of synthesizing knowledge almost in an academic sense. We did this work with Transport for London, and there are other cities that have similar buses. And I'm trying to consider, were you aware of any work where the work you're doing in London was, say, maybe being taken to Birmingham to protect Carla's brother, or Edinburgh, or Berlin, or somewhere else? So, you know, because again, there's that issue about how do you spread this really important work? You know, not just, it's great that TfL took this up, but beyond London.
Yeah, and that's, I mean, we had to wait for a while until a number of issues were resolved, and until we were also sure that certainly, you know, all the new science that keeps coming out, as you've asked before, is still, you know, consistent with what we believe to be true. The issue as well is we do collaborate with TRAC. That's a larger scale project run by the Department for Transport to look at the country as a whole. But of course, the problems are completely different, and we have to be also very careful, because a London bus driver's experience is not the same as the experience of someone driving a coach from Cambridge to Stansted. The number of passengers they're exposed to every day is very different. The type of passengers that use the service and how long they've been on it. There's so many different interactions that are very different. And that's where we also have to, we can kind of say, this is what we've been doing, this was our approach, but it might not work there. So there's a lot of work that needs to be done.
I mean, that's one of the reasons, one of the basic principles is about replication, because often what we've had is almost like a single study of either, you know, a transmission route or prevention activity within a single context, which is you know, bounded by the social cultural aspect, by the by the physical environment, by other factors. And so, yeah, I mean, once we discover these things, I think one of the core elements is that, you know, it would be great if globally, prospectively, we could start to say, what are the factors that might vary? And can we start to sort of replicate this work to see whether, if you're a coach driver on a long, you know, doing a 2-hour stint, you know, what are the realities for that person, as opposed to someone doing driving a bus where people are coming in and out relatively quickly for short stints. So I'll pause there. Sorry, Susan.
That's fine.
Yeah, absolutely. And there are buses like the London buses in Hong Kong, for example. And what I would really like to know is, how did they manage to convince everyone to wear face coverings so easily?
On the question of face coverings, I should say, as chair, we've got up to 10 minutes left. So if anybody's got any other questions or comments, just type your name in to the Q&As, and we'll call on you. But meanwhile, just out of interest, something more on face masks. I mean, obviously face masks are really effective if you're the infected person and you're coughing and sneezing, to keep the droplets by your face. But what's the evidence for how effective they are from aerosols? So, for example, a teacher teaching in a classroom, everybody's sitting 2 meters apart. You know, nobody's going to be coughing or getting droplets into each other's faces. But say it's not ventilated well, so if there are aerosols, if someone's infected, there will be aerosol around. Like asking school students to wear face masks all day in that situation, is that helpful? Does that protect them from the aerosol, or is it just the droplets mainly?
It would protect them from the aerosols as well.
Mm-hmm. Mm-hmm. Presumably,
The simple answer is it would work. The evidence is that if you have both the person breathing out and the person breathing in are both wearing face masks, then the number of droplets and aerosols that can reach from one to the other would drop dramatically. And that's even for the poorer face coverings, not only for the very high-end ones.
Yeah, that's good to know. Thank you. Paul.
Susan, can I just come in on that? Because one of the things we've been looking at all of the trials of face masks, and one of the concerns has been the lack of eye protection. We know from influenza experiments that virus can get in through the eyes and down the nasolacrimal duct, so you can get infected that way. And interestingly, there have been 2 before-after studies, one of healthcare workers in India, where they were getting infected despite wearing masks. They added face shields to the masks and the infection rate dropped to 0. And there's been a similar study just come out recently in the US as well. So the 2 questions there, one is about the potential of a face mask and whether people are doing the face shield in addition to a mask, and whether people are studying the flow around different types and designs of face shields.
Yeah, so we haven't done that ourselves, but there are many people who are carrying out all sorts of tests like this on different types of face coverings and face shields. It would be very similar to the kind of airflow modeling that I've shown for around a bus shield, basically an assault screen. And with the face shields, I think that for healthcare workers who are exposed to large doses of the virus all the time, they need as much protection as they can have. But for people who are walking around, the choice to wear a face shield instead of a face mask is not particularly helpful, because for one thing, it doesn't protect people from you because what you're breathing out is still out there. And for another, it does seem that still the virus lodges first in the nose and more than it does in the eyes. So if you did have to choose one, face mask would be more effective. And wearing both is really difficult, especially if you have eyewear, and it takes away your power. It's a democratizing thing, isn't it? Suddenly everyone is exactly the same behind their face masks. And I really do think that's why everyone hates them. They can't smile, they can't engage with other people in the same way. They feel diminished in a way, and that's the cultural shift that has to happen, that we have to accept being diminished in that way to be safer.
Gosh, we could have webinars about so many of these things we've talked about. So I've got another question from Ian Chalmers. Ian, be great, Lucas, if you'd unmute Ian, and then Jeremy wants to reply to Ian's question, and then we'll have to draw it to a close, sadly. Ian, nice to hear from you.
Thank you very much, Susan. It was just that while listening to the discussion, I was wondering about whether there is, whether measures are being taken to try and avoid biased underreporting of studies where the results haven't shown what one might have hoped that they would show. So I wondered about, for example, prospective registration of studies of the kind that you've been reporting, Leora. And by the way, thank you very much indeed for your presentation.
Yeah, I think that's a really fair point, and I think that's something that one of the reasons it would be good to actually work more with the medical community is that they do have a very, very high standards and methods for actually carrying out systematic literature reviews. How do you actually absorb 2,000 studies and classify them in such a way and use all of them together to make a decision? We work in a very different way. We work on rigor of understanding a physical mechanism, demonstrating how it works and then being convinced by the numbers. And for me, it would be enough to have one study by a very well-respected team that can be replicated and with results that are very robust. And I know that that would be very different in the medical community. So we don't have a systematic way of doing that in our field.
So both
Can I-
Jeremy and Paul want to get in. So literally 1 minute each, sadly, because we're drawing to a close. Jeremy.
So I mean, one of the things you said, Leora, is about the importance of replication, and that's what we would say as part of that. I think one of the challenges at the moment is you almost have this one-off example, and we have no idea whether that example was chosen because it was somehow different to a representative set of similar circumstances. So, you know, the 1 or 2 studies that talk about transmission in planes, there are millions of planes that are traveling, or thousands are traveling every day, and we get told about 2 of them. But the data probably is out there to go back and actually sort of say, okay, well, what happened to all the other planes, particularly in countries that have, you know, really good sort of prospective or sort of track and tracing. So I agree with Ian, but I think also, you know, what we've got is probably a big lots of data sitting out there that at the moment we're not fully utilizing, which would also be really cool to do. I'll cede my point to Paul.
So in a similar vein, I just wanted to come back to Ian's question, Leora, which was about whether you prospectively register, place in the public domain the study that you're doing as you're starting it, so that other scientists around the world could know that you're doing that, so you could get together and discuss why your studies or methods were different.
Yes, I mean we're doing that now. It's something that we're able to discuss now that that the project that the first phase of the project has been completed. But in terms of learning from other scientists, there are many webinars like this in our field with scientists from fluid dynamics and aerosol science, and we've been talking quite regularly and
actually,
maybe learning from them.
The sort of the perspective, the pre-registration is partly to inform people really early on, but it's also partly to do with good science, so that people know, you know, all the research that was planned and that was being done, and you can't just lose some of them in the bottom of the filing cabinet drawer somewhere. They all are in the public domain, and also by saying what your methods are going to be, you know, you have to kind of stick with that. You can't have your findings and then change your research question to suit your findings. So, you know, it's made in the kind of parts of science that have taken this up, it's made a fantastic difference to the quality of the science and the confidence that one can have in the findings. So it's great to hear that engineering sciences are going in that direction too.
Yeah, the tweeting their results as they come out, absolutely.
Leora, that's been absolutely fascinating. I really wish we had another hour to talk about all these issues that have been raised. But that's what the webinars are for, to get us thinking, to get us interacting with each other, to get ideas going. And certainly I would love to follow up with you and Lena about more aspects of your work. So on behalf of all of us, thank you very much. We'll just before we go, put on the details of our next webinar, which is on Thursday, 26th of November. And we've got 2 people coming from Uruguay who have handled the pandemic really well. So we really want to find out from them what they've been doing. And also Melinda Frost from the WHO, who will have a kind of overall perspective of you know, some of the ingredients for successful management of the pandemic. So Leora, thanks yet again. I mean, the E bit of BESI is really important. And so we'd love to have you and your colleagues more actively involved with the collaboration. So let's keep speaking. And thank you to everybody who joined us today and for your great questions and comments. And look forward to as many of you as possible next time. So goodbye all. And thank you again, Leora. It's great.
Thank you.
Bye.
Bye, everyone. So we should definitely join your